Hey, practice owners, we're back for another edition of Coming Back Stronger. Very excited to have our guest on. If you've been around dentistry for any time at all, you'll recognize Dr. Tom Orent, the GEMS guy. And he has been gracious enough to come to us from his home studio in quarantine and share some of those gems today on how you might come back stronger. So, Dr. Orent, how are you today?
Call me Tom. Steve, how are you doing? I'm doing great.
Fantastic. Now, so where are you? Where do you live?
I am just outside of Boston, a little tiny town called Sherborne, Massachusetts. And in fact, we have more horses in Sherborne than we have people. There's only 4,000 people in the town.
That's my kind of town. Grew up the same way, more cows than people. So,
Yep.
So kind of dive right in here. You've been in dentistry a long time. Your career is really sharing advice, gems. And one of the reasons I reached out was hoping that you had some gems for coming back stronger. So if we could, can we start like at I don't know, 30,000 foot view and maybe get you to share what you see going on right now, again, we talked beforehand, we're both of a vintage enough that we've lived through a few economic downturns, nothing like this, of course, but enough to have gained a little bit of wisdom. So, from a high level view, satellite view, so to speak, can you start there and kind of share what you see?
Sure. I want to go backwards a little bit.
Okay.
You talked about I've been in dentistry for a long time, kind of sharing ideas. Just to be clear, I actually was a dentist.
Mm-hmm.
Suppose I still am to some extent. Practiced for 22 years and 15 years into practice, almost lost my house, I did lose my wife. She divorced me actually. My office manager embezzled me. I was $1 million in debt and I had absolutely no clue what was going on. And basically I created my own recession. So I just want to start out by saying, I've been pretty much where you guys are. The only difference was we didn't have to wear a mask when we walked outside. But other than that, it was downright desolate. But it wasn't for a month or two. It was for about 2 or 3 years. Now, I actually have a trivia question for you. And we didn't talk about this before because I didn't want to give it away. I don't know if you know the answer to it or not, but are you ready?
I'll try.
Okay. Who was the, how do I phrase this so I make sure you can get this? What do you know about a newsletter called the Nationwide Dental Newsletter?
I've heard of it. I have a binder full of copies of it right out here.
All right. It was going to be too.
Well, it really set the, and I didn't realize this as I got into, joined up with Dr. Woody Oakes just a few years ago, but it was kind of the first of its kind. And Woody literally printed it in the basement of the dental office on a copier, like an old Xerox copier.
I was a subscriber to the original Nationwide Dental Newsletter. And he used to do something called the $100,000 challenge. I don't know if you've read any of those or not.
Yes, yes.
But that was a big deal. And we would get that every month. And it was one piece of the puzzle. And it would take you like a year to figure. Anyway, so a little bit of trivia there.
Well, excuse me. And for those who don't know, that was the predecessor to the Profitable Dentist.
Right. Now, I got a little bit more trivia here. A little bit more trivia. Who helped Woody to rename that from Nationwide Dental Newsletter, which was okay, to the Profitable Dentist, which was brilliant?
I know Travis McPhee was involved at the beginning.
Yeah.
But I don't know if he was involved at that point at the transition.
He was involved. He was involved at that time.
Dr. McPhee.
However, to my knowledge, I don't believe it was either Travis or Woody who came up with the new name. I believe it was one of my mentors in marketing, Dan Kennedy.
Oh, okay. I could see that. Yeah.
Pretty sure that happened.
I'm gonna make a note here. I'm gonna check. I'm gonna find that out and
ask Woody. Tell Woody I've always assumed that, and Woody was brilliant, still is brilliant, I'm sure. And do tell him I said hi because I have a really nice spot in my heart for him.
Will do.
He and I went way back. But one more tiny bit of trivia, and then we'll get started because I know probably you want to hear a couple of gems. This is not a question, but just a comment on who gave me my biggest first start in speaking. And the reason my voice is as bad as it is because I spoke for over 20 years on the circuit. I was at the top of a mountain in Colorado. I can't remember the name of it, but I was at the top of a mountain in Colorado as one of maybe 10 or 12 speakers over 3 days, audience of over 1,000 people. And it was the biggest audience I'd ever spoken to early in my career. and it was Woody and Travis doing The Profitable Dentist at the top of some mountain in Colorado.
Mm-hmm.
So anyway, here's a satellite view. The satellite view is everybody's making a big deal, understandably, saying that this is a terrible situation. And I'm not just talking about the health part. The health part is just terrible. And there are a lot of people who got very ill and of course some who passed away. So that is terrible. But looking only at the business side of this, a lot of people are looking at it and saying, well, it's going to be terrible going back. It's going to be very difficult to make money. It's going to be difficult to get back into practice. And I consider myself, and I always have, what I call, and I kind of coined this, I'm a realistic optimist. A realistic optimist, meaning I'm always optimistic. I always find, I don't even find the silver lining. I do better than that. My wife, Elizabeth, says that I make lemon chiffon pie out of lemons. So not just lemonade. So I'm always optimistic. Having said that, I think it's going to be worse and harder than people think it is. Mm-hmm. So I'm going to give you a little bit of a twist on this. I don't think people are being accurate when they say it's going to be difficult. I think there's a lot of dentists who are going to go bankrupt fairly quickly. I think there's a lot of dentists, because this is what I'm hearing from my members, who are just going to give up and retire because they were kind of on the edge anyway. Mm-hmm. They were late 50s, early 60s, some of them older than that, and they were thinking about maybe selling. I think some of them are simply going to be closing. Mm-hmm. And you're seeing it happening. So now you've got the rest of us, the dentists who still want to practice, still have to practice maybe, and of course I'm not in that. I sold my practices 16 years ago, but for those dentists who this is your livelihood and you need to figure out how to make this work, I will guarantee you there are not only going to be people who will survive, but there will be those of you who thrive. And you already know that. It's going to be a bell curve. And what I say to my members is, as long as we know that there's going to be people who not just survive, but actually thrive in the next 12 months, it's a choice. You might as well make the choice to do that. Steve, I think what you've been doing for this whole week with that unbelievable schedule of speakers, which is just the best, is so generous of you and so good for all of the dentists. So then the question becomes, what's the shift that we need to make in order to make this happen? So I think that if you were to write down two words to start, the two words would be patient-centric. Patient-centric. And here's why. When I was getting out of dental school, and yes, we had electricity. We did have electricity, yeah. We had electricity. So when I got out of dental school, it was put a shingle out, and kind of the golden era of dentistry had kind of just gone down a little bit. I actually got out in a recession, so it wasn't that easy. But the point is, it was very, very different that you could be off on Wednesdays golfing. Not that I ever golfed. I play a lot of volleyball, still do. But you could be out on Wednesdays. You didn't have to be there Saturdays. You didn't have to be in early in the morning, and you certainly didn't want to be there at night. And it was just very different. And it was kind of more like banker's hours. And patients would kid dentists. Now, if you're 50 or older, you know this, because patients would kid us that you have such an easy job, you have such an easy life, you have kind of banker's hours, and you can only work 4 days a week, and some of us 3, and some of us less at the end. So we had it really easy for many, many years. Well, the ones who are going to thrive, it's not going to be easy, but it's totally doable. So with that, and you and I talked a little bit before that I wanted to touch on 2 gems, and I think the first one was scheduling, maybe?
Scheduling better. Mm-hmm.
All right, so let's talk about scheduling, how that relates to being patient-centric.
Okay.
The first thing I want to talk about is something I actually picked up at a seminar that I was speaking at a seminar in Vegas, got to be 8, 9 years ago, and I heard one of the speakers talking about something he called, actually he didn't call this, but anyway, I can't remember who it was, and I don't know what he called it. I'm just going to tell you what I call it.
Okay.
I call it the donut hole. I've written a lot about the donut hole. Why? Because there's a lot here, there's a lot there, but in the middle, there's nothing. Mm-hmm. Now, if you look at your schedule before COVID, before the virus, well, you probably had a fairly good schedule, but if you look carefully by the end of the day, the part that really got kind of Swiss cheesed by people either calling and saying at the last minute, I can't make it, I just can't go in, or no showing, which is even worse.
Right.
That was kind of the 10 a.m., 11 a.m. to 2, 3, 4 So why were they doing that in that period of the day? Well, the reason was because they were at work and they decided they needed to stay at work. And some of them were kind enough to call, and some of them just blew us off and no-showed. And that really was terrible, but that's what happened. What you're going to see if you look now moving forward, when you come back to work after COVID, what you're going to see is exponentially worse middle of the day. Some of them won't schedule at all for fear of losing their jobs or risking their jobs. I was reading yesterday in the Wall Street Journal, the IMO, International Monetary, these guys are looking and saying it's going to be the worst period of time since the Great Depression. Now, they're not saying it's going to be a depression, but they said it will be worse than any recession. And this was in the Wall Street Journal this week. So their fear is, again, if you want to be patient-centric, you got to realize they have two major fears when it comes, actually three major fears when it comes to coming back into our offices. Not in any order. Number one is, I don't want to risk my employer saying, you know what, you're taking time off for a cleaning, goodbye. Number two is when they get there, they're not going to be so quick and easy to part with money. So we don't have time today to go into 3 or 4 gems, but one of them that I would think about would be, you need to finance in ways that you never have before. Not outside, not external, because most of them are going to be turned down. Pre-COVID, 50% of them were being turned down by Care Credit, Beneficial, Capital One. 50% in the US were already turned down. And that's when things were good. When you look at 8, 9, 10% unemployment, or maybe even double digits, they're going to fear for their jobs. So be patient-centric, realize that you need to bend over backwards financing-wise. At the same time, and I wish I had time to go into a lot of detail, but obviously we got to stick to a few gems here. At the same time, you need to mitigate risk. So when you look at long-term internal financing, we were doing 2.2 million, 400,000 of that we would do internal long-term financing. And this is back, I sold 16 years ago, so this was back a long time ago. Today we would probably be doing 600,000-700,000 in internal long-term financing. We only lost 1.5 to 2% a year on the people that we were financing because of bad debt. The rest of it we collected, and the best part of it was there was a one-time simple service fee on all that money, and that was anywhere on a sliding scale of 8 to 12% one time ahead of time. And so you're not doing it for free. Some of the worst advice we have ever been given by the gurus is don't be your patient's bank. If you understand how to mitigate the risk, if you understand how to do it legally and properly, you can make a fortune doing it. And if I were coming back today to practice, this would be the time that I would be implementing internal long-term financing. Again, I would never start with it. I would always start with a 1-pay, 2-pay, prepay for a courtesy, everything else that you're normally doing. And then go into Care Credit and Beneficial and Capital One. I'd do all those things first. And I would never let anybody know that I had any other option. But then when they're sitting at the desk and they want to do those 2 crowns because they know those 2 teeth are going to break and they just don't want that to happen, I would say to them, meaning my team member would say to them, maybe there's another way we can do this. So it's not even on the forms at that point. It's not handed to them. It's just something that you kind of throw in there at the very end before they walk out and say, I can't have it happen. Let's go back to scheduling. Look at the donut hole. So they don't want to be there in the middle of the day. Some of them, by the way, will schedule and then they're going to blow you off. So you got to do something different. The donut hole says, go in earlier. Now, we used to be open. You are sitting down. I can see you.
Yes.
I was going to say, are you sitting down? We used to work from 7 a.m. to 10 p.m. in my office. Now, in my main office, in the Worcester office, it wasn't quite as late at night. It was to 8 p.m. But 7 a.m. So 7 a.m. to 8 in Worcester, 7 a.m. to 10 p.m. in Framingham. Now, you might say, Tom, that's kind of a long day. Well, we never worked. No one person ever worked all those hours. So if I was working at 7 a.m. first patient, then the meeting was at 20 to 7, which means the staff needed to be in there, before that. So it was a 20 of 7 meeting, 7 o'clock first patient in the chair, but then we were all out, except for one person answered phones. We were all out by 2 p.m. So 7 to 2 was what I called a straight 7, and that's the next gem of scheduling is the straight 7. Now the straight 7 says you don't schedule lunch. You don't take a lunch break. Well, why wouldn't you schedule a lunch? Okay, for 2 reasons. Number one is even if you are still doing a normal day, an 8 to 5, let's say, and by the way, if you're doing an 8 to 5 over the next few months, I think you're going to have a real serious issue with being able to rebuild your practice. So minimally I'd open at 7, but I wouldn't be working past 2 on that day. So here's one of the reasons, even if you were working a normal schedule, let's say 8 or 9 to 5, the reason I still wouldn't schedule lunch is this. And I'm going to ask you this, Steve. It's rhetorical, but I want you to answer it so that the viewers can hear you basically saying what they're thinking in their minds.
Okay.
What do you and the team do for about a half hour before lunch? You're the doctor, you're sitting there working, you're looking at your watch, you're looking at your clock, the team's doing the same thing. What are they doing psychologically in their heads, emotionally? What are they doing for the last half hour before lunch?
Whatever they've planned. And, you know, there's a term for this. Somebody used it. It's like your vacation brain. The week before you're on vacation, you're thinking about vacation.
Totally.
You know, you're useless for that, you know, especially Wednesday, Thursday, and Friday. You're already there.
Yeah. So I like the vacation brain. So this is the lunch brain. We'll call that the lunch brain.
Lunch brain. Yep.
So you're not as productive for about a half hour before lunch as you otherwise would be if you were working straight through. Now, worse than that, what happens coming back from lunch? Let's say you take a 12 to 1 lunch or 1 to 2, doesn't matter what the timing is. When you come back from your lunch hour, what happens from that point on?
You're the same thing. You are easing back in. So really a lunch hour is probably 2.
It's 2 hours.
Yeah.
So it's 2 hours of lost productivity. If you work straight through, you could do a straight 6 if you want. If you don't have the fortitude to work a straight 7, you could work a straight 6. So we would work 7 a.m. to 2 p.m. And by the way, you're going to have somebody no-show. You're going to have somebody who, whatever, they came in late. So you'll be able to grab something to eat at one point, but you just don't schedule it. All right. So 7 a.m. to 2 p.m. On other days, we would do 3 to 10. So now, people used to think I was nuts working until 10 p.m. I will tell you that patients were so appreciative of the 8 and 9 p.m. appointments. And this was back in the day when there wasn't even that bad a recession. This was during kind of normal times. So it's at 7 to 8 p.m. I'm sorry, yeah, 7 a.m. Sorry, 7 p.m. and 8 p.m. And even the 9 p.m. was always booked. One of my members is open 7 days a week, and full days, not Sunday 5 hours. And Sunday is her busiest day. And in one location, she's doing over $5 million. So now she was doing this before COVID. COVID. So she is a prime example of somebody who got patient centricity even before it was really required to survive or to thrive. So now, if you're doing 7 a.m., maybe I do, and you can choose the days, but maybe I do one day 7 a.m. to 2 p.m. Maybe the next day we come in at 3 o'clock in the afternoon and work till, and you don't have to be there till 10, but be there at least till 9. At least till 9, because you're going to find that your busiest times are anywhere from 7 to about 9 before work, and from about 4 until 9 or 10 after work. And also Saturdays and Sundays. And people used to think I was nuts suggesting Sundays. I have a lot of members who are open Sundays. My recommendation would be, if you've got 2 doctors, you should be open 7 days a week. If you have 2 GPs, you should be open 7 days a week. If you only have 1 GP, then be open 4 or 5 days, whatever you want to do. But I would be open every day except for Saturday and Sunday. I'm sorry, let me rephrase that. I would be open Saturday and Sunday, and then I would take my weekend off in the middle of the week, maybe either Tuesday and Thursday or Tuesday and Wednesday, but take 2 days off when people don't want to come in because they're working. So that's patient-centric. The hours starting early, the hours staying open late. The working straight through allows you to get out of there earlier and come in later on the day that you're there later. So that's a little bit about that. Now, I also got a really cool gem, and I wish I could take credit for this one, but this was from a friend of mine named John a number of years back, about during these really early morning hours and during these late evening hours. So let's say, not even late, let's say 4 p.m. to 9, and from 7 a.m. to 9 or 10 a.m., you want to get in as much hygiene as you can. Why? Because if a patient has to make a decision to take some time off of work to come into your practice, which do you think they're going to feel a little bit better about doing? Going to see the dentist for something that's really important, restorative, or going in for just a cleaning? Now, if you're a hygienist watching this, I get it. Cleanings are as if not more important. Keeping up the oral health, keeping up the periodontal health. The oral systemic link right now is amazing, the depth of information and knowledge. In fact, interviews, Monday I did a 4-hour interview, not me interviewing Dr. Whit Wilkerson, and it was all about the oral systemic link. And so this is another thing. I would urge you guys to follow Whit, follow Jim Metz, follow all of the people who are sharing with us this amazing medical knowledge, which ties in sleep apnea, breathing. I did an interview, I had Jim Metz, and we were talking about nasal breathing, and I learned so much that I made my whole family watch this interview. It's like a 45-minute interview on nasal breathing and understanding why you should never be breathing through your mouth, as in ever. It has nothing to do with being in dentistry, it has to do with health. So now, can you help your patients with this information? 100%. You can help your patients be much healthier if you understand more of this information. So those would be some of the things I'd be looking at. Let me go back to the hygiene, because I just wanted to point out hygiene is as, if not more important, but the patient would rather go see the doctor midday than they would to see a hygienist for a cleaning. They just think they need to be at work. So you got a little bit of a disadvantage right now. The ideal way to really make the donut hole work is to run 4 chairs of hygiene simultaneously from 7 a.m. to 9 or 10 a.m. and then from 4 p.m. until whenever you close, which is either 6, 7, or 8 or 9 p.m., however late you can stay. The reason that that's really an advantage is if you can run 4 chairs of hygiene, and by the way, you can do that with 2 hygienists.
Mm-hmm.
You could even do 3 chairs with 1 hygienist. And here's how you do that. You do assisted hygiene for 2 chairs. So you have a dedicated assistant who's working with a hygienist. And I'm sure you all know assisted hygiene, but for those of you who may be not familiar with it, I'll give you the really short view of it. The short view is you're going back and forth between when the assistant is in the room and when the hygienist is in the room. So for example, the assistant would turn over the room, clean it, sterilize it, and disinfect it, do all that stuff. Get the room ready, do the setup. The assistant would bring the patient in. The assistant would do all the x-rays, any intraoral photographs necessary. Everything except for probing, obviously the assistant can't probe. Right. So the assistant does, if you're doing Diagnodent or CariView or Canary, or you have one of those, they'd be doing that. If you're using transillumination for crack finding, they would be doing that. Everything that can be done diagnostically legally by a dental assistant in your state should be done by an assistant. Why? Because you pay the assistants less. Mm-hmm. Now, an assistant is a very, very valuable team member, unbelievably valuable. If they're trained properly, maybe one of the most valuable on the whole team. However, they're still going to be paid less because that's just the way it is in dentistry. Mm-hmm. So the assistant does everything I just described, and that's about 15 minutes worth of work, maybe even 20 minutes worth of work. Now, the hygienist comes in and scales the teeth and talks to the patient about what the assistant found, almost as if they were the doctor. So some of my members say, well, Tom, in my state, it's not legal. By our board of registration doesn't allow a hygienist to diagnose or treatment plan. Mm-hmm. Well, there is no state in the United States that allows that, and there's no province in Canada that allows that, and outside the US, probably the same thing. So how did we do that? We had 35 team members, and we had 5 hygienists, and this is exactly what we did. Now, I'm not an attorney, and Steve's not an attorney, so neither of us can give you legal advice. You should ask your attorney, but having said that, there's my disclaimer. Having said that, this is what I told my team to say, and this is what worked really well for us. So let's say you used transillumination and you found a deep, deep dent and crack, and you did an intraoral photograph and you saw recurrent caries, and you used all these different things, and here's what you know that when the doctor's going to walk in, he's going to say these two teeth need to build up and crown immediately, and so forth. If that's the case, I have something that I call my bobble-headed dog syndrome. I want you and me, oh, that's right or not? No, I think I want you and I. Anyway, my English teacher in senior year said to me, how am I going to send you to college? You can't write, you can't speak. I said, maybe I'll do it for a career. Who knows? So seriously. So what are we going to say? Oh, I want to be the bobble-headed dog. Mm-hmm. The bobble-headed dog is this. If you train your team on the psychological, as Cialdini would say, the use of ethical influence. Ethical influence is understanding psychological triggers so that you can use Dan Kennedy's formula of problem, agitate, solution. The problem is the deep crack. The problem is the recurrent caries. The solution is a buildup in crown. And in dental school, and even in continuing education, unfortunately, we're told to shortcut that, where we just show them the problem, tell them about the problem, and then show them the solution, propose it, tell them how much it is, and wonder why they didn't schedule. So Dan Kennedy would tell us the reason is because the agitate step was missing. Well, what is the agitate step? The agitate step is when you use psychological triggers, and there's lots of them that you can use. It depends on what the problem is, but you use psychological triggers to help them get emotionally involved and understand the gravity of the situation. And in the short time that we have, I'll just write down, tell them about the potential consequences of not treating. Tell them about the potential consequences of inaction. Because if you could share that with them, if you could let them know, this is what I see happening. This is what could happen. We've seen this happen before. I don't want that to happen to you. And you let them know. All right, so let's back up a little bit. What's the bobble-headed dog? And why did I mention that? The bobble-headed dog is me, the dentist, or you, the dentist, walking in the room after a hygienist has done a great job, problem, agitate, solution. And we just walk in and we go, Mary, yeah, I am really concerned about that. I'm glad you found that for Mrs. Jones. And basically, you're bobbling your head up and down like the little bobble-headed dog in the back of a car when it comes to the stoplight. So my exams, my re-exams, were really, really short. Even if it was a $4,000 or $5,000 little quadrant of inlays, onlays, crowns, whatever, it was still really short because I didn't walk in there and start to tell a dental patient. If you tell a dental patient, if you're a dentist and you walk in after they've done the cleaning, and you walk in and you tell a dental patient who is asymptomatic, so there's no symptoms, and that's 95% of the care that we render is to asymptomatic patients. If you walk in and tell an asymptomatic patient that they need $3,000, $4,000 worth of work when the hygienist didn't mention anything about any of that, their response to you, again, rhetorical question, Steve, you're the patient, everything feels fine, nothing's broken, hygienist didn't say anything was wrong. I walk in and I say, oh, nice to see you. Oh, yes, you need this, this, and this is going to be $5,000. What's your response to me? What's the knee-jerk classic patient response to the doctor who said you need $5,000 worth of care when nothing's broken, nothing hurts, and the hygienist never said a word?
Yeah, the hygienist hasn't teed up anything for you, and so suddenly, like, this is all news. You think, and I think that's the part of that communication breakdown. Is you think everything's fine because she hasn't mentioned anything.
Yes.
And it's just a formality now. Doc's going to come in and talk about, kids and school and volleyball and then move on. And suddenly you're right.
And what I used to hear was, am I sending your kids to college or do you need a new Mercedes? And I said this to one of my members who was out in Newport Beach, California. And he said, nobody's ever said that to me. And I was shocked because almost every dentist has heard this. He says, I said, how is that possible that nobody's, because you're on the other side of the world, I'm in Boston area, you're in Newport Beach. Why does nobody say that to you? He laughed. He says, because they're asking me, do I need a new, bigger boat?
Ah, right.
So the gut reaction is, you're doing this for the money, doc, and I'm not going to do this because I don't see any reason I would need any of this. Now, Steve, let me ask you another question because I'm kind of liking where we're going with this. Why would they trust the hygienist more than the doctor? The doctor's got a degree. The hygienist degree is a 2-year degree. The doctor's got 4 years plus 4 years of college. That's 8 years. Why would they trust the hygienist more than the doctor if the hygienist says, oh my goodness, I see this, this, and this, and that, and so forth?
I think I would see it as the team. They trust the team, and there's a process. Yeah. And the hygienist is a trusted part of that team.
Yeah.
And I always feel it's more comfortable when maybe in a sense, and maybe that's where this goes, the doctor is just sort of reinforcing what the hygienist already said.
Exactly.
And and the patient says, so that's what they think we need. And
exactly.
Yeah.
So you hit it when you said reinforces. I want to be a second opinion. If you're writing any notes, and I hope you're writing notes, if you're writing down second opinion, that's 100% because you want to walk in as the bobble-headed dog being a second opinion to what your hygienist has already said. See, the patient sees a money trail, as I mentioned a moment ago. The patient sees a money trail to the doctor and doesn't quite see that same money trail with the hygienist because hygienist can get paid whether she does the job or not, or whether she recommends work or not. So let me move back to something that I need to finish because people are going to say, you gave your legal disclaimer, but you never told us the verbal skill. Okay, so the legal disclaimer was, we're not attorneys, check with yours, but here's what I told my team. And we had 2 guys and 3 women, so we had 5 hygienists, but 2 were male. It was kind of interesting mix, but they were all phenomenal. Our hygienist would say the following: Mary, I'm not a doctor, so I can't diagnose or treatment plan, but I've been working with Dr. Orent for whatever, let's say it's 7 years. I've been working with Dr. Orent for 7 years now, and I can tell you exactly what he's going to say when he comes into the room. Now, again, I'm going to repeat it because that is a verbal skill word for word that my entire team used. All 5 hygienists use that in both offices. Mary, I'm not a doctor, so I can't diagnose a treatment plan, but I've been working with Dr. Orent for 7 years, and I can tell you exactly what he's going to say when he walks into the room. Now, if you use that, and if your attorney says that's fine, and I'm sure they will, so if you use that, then you can go ahead and tell them what you see. Use psychological triggers. Again, they depend on what the issue is, and then the recommendation. Now, sometimes I have a hygienist say, well, I don't know exactly what he's going to recommend. Yeah, you do for most stuff. I'm not talking about a complex case. I'm not talking about a periopros case that's going to be $50,000. I'm talking about a quadrant where there's MODBL amalgams in there that have been in there for 30 years and have wide open margins, and you know that he's going to do crown and bridge. Right. So you don't have to be exact, but you could say, these are gone past the point of repairing with another filling, and I'm certain he's going to walk in here and tell you that if we don't do this, this could happen, and so forth. So it doesn't have to be exact, but as long as it's close, when he walks in and reinforce. Okay, so I think we've explained that pretty well. I said that you could do 3 chairs of hygiene with just one hygienist. Let me explain that one. The way that you do that, God, we got off on so many tangents. I also said I would explain how you do the assisted hygiene.
It is a wealth of information here. So I quit taking notes a minute ago, and I thought, all right, I'm just going to re-listen to this.
You're too funny. Do you know who Bill Glazer is? Okay. So one time Bill interviewed me for GKIC, and I've actually spoken on their platform to marketing audiences a number of times. So Bill interviews me once before one of those as kind of a preview phone interview. And Bill says, at the end of the interview, I could tell he was shaking his head. Now, I couldn't see him, but I could tell he was shaking his head. And he said, Tom, he said, you've proven one thing at the end of this interview. I said, what's that? He said, you've proven that a human being can speak for 28 minutes without breathing. So, all right. So quickly on the assisted hygiene, and then, oh goodness. Okay, so the assisted hygiene, three hygiene rooms. If you have an assistant working back and forth with you, I said they go in for 20 minutes or so, they do all this setup, then the hygienist comes in. That's where we got off on what they need to say. Now the hygienist says all this stuff, preheats, as you said, tees off or preheats the patient. Patient totally understands not only what's wrong, but what some of the potential resolution might be treatment-wise, and is agitated emotionally that they need to get something done. And my goodness, guys, this works really, really well. It works really, really well, much better than you walking in and trying to tell a patient what they need. All right. Then when the hygienist is done scaling, most, not all, but most states will allow an assistant to rubber cup polish, kind of prophylaxis, super gingival with the polishing paste. And if your state allows that, and most do, if your state or province in Canada allows that, then the assistant, the dedicated assistant, comes back in, and he or she now does the polishing, fluoride at the end, any final notes, bringing the patient back out, scheduling the patient for the next visit, helping schedule any restorative, and then bringing the patient out and out of the office. And obviously financial can be done either by the assistant or by somebody in the business staff, and that depends on the size of your staff. When the assistant was not in that room, the assistant was doing the exact same thing for room 2 for the hygienist, and they just keep going back and forth. It takes less than 30 minutes for a hygienist to scale teeth in the absence of not even severe, in the absence of a lot of subgingival calculus, in the absence of a lot of deep pocketing, in the absence of a lot of 5 and 6 millimeter bleeding pockets and periodontal disease. So you might, devil's advocate, ask me, well, what if that patient does have 5, 6, 7 millimeter pockets, or even 5 and 6, and a lot of bleeding and a lot of calculus? They're not going to be able to get it done that quickly. And I hope if you're watching this at home, or maybe with your team on a Zoom meeting, I hope what you're saying is, Tom, that's a pretty obvious answer. That patient shouldn't be having just a cleaning. That's a periodontal patient. So with periodontal patients out of that picture, because they need anesthetic, they need bi-quadrant scaling, they need a prophy as well, but these are 2 separate issues. All right, so let me get to the how do you do 3 chairs, because I think I hit enough on how do you do the scheduling. How do you do the 3 chairs? You have a dedicated assistant and a hygienist work in room 1 and room 2. In room 3, again, your state has to allow it, but most states do. You're doing kids only, and you're only doing rubber cup prophy and x-rays. Now, the assistant in most states needs to be x-ray certified, and hopefully they are. So they're taking the x-rays, they're doing charting, they're doing rubber cup prophy, they're doing fluoride. The only thing that they really can't do is the exam, and the doctor's going to come in and check the patient. So you can do 3 rooms. In states that allow what I've just described, you can do 3 rooms of simultaneous hygiene. Now, if you're doing 3 rooms of simultaneous hygiene, or even 4 if you had 2 assistants, but if you're doing 3 or 4 rooms and you do donut hole schedule, let's say you're doing 3 rooms and you do 3 hours in the morning and 3 hours at night. That's 6 hours, 3 rooms. That's 18 hygiene patients. Now, devil's advocate. That's fine, but I see a problem with this, Tom. Yeah, I do too. Here's the problem. And I don't know if you see this, Steve, but I know the doctor's going to see this in a heartbeat. Mm-hmm. How am I going to do re-exams on 18 patients during such a short window of time when I'm seeing patients? Mm-hmm. The answer is there's no way in heaven that you can do that. Uh-huh. It's a G-rated thing here. There's no way in heaven that you can do that. So how do you do this? You do not see patients during the early morning hours from, let's say, 7 a.m. to 8:30 or 9, and you don't see patients from the, let's say, 6 to 8, 6 to 9, 6 to 10, whatever it is you want to do for later hours. All you do is re-exams. So you're going room to room to room. Now, if you didn't have any patients at all to see, you're not doing restorative dentistry, you're not doing endo, you're not doing anything, could you do 4 re-exams an hour? Yeah. Not only could you do it, but now you wouldn't be rushed. And if you're assistant and hygienist, or assistant or hygienist, depending on if you're doing assisted hygiene or not, if your support staff, your support team is doing a great job, as Steve said, of teeing off the patient, what we call preheating emotionally, and you walk in as the bald-headed dog, you're going to sell a whole lot more. And it is selling. It's, as Cialdini would say, it's ethical sales.
Right.
You are ethically influencing patients to do what you believe in their heart, in your heart and mind, is best for those patients. Mm-hmm. All right. I said that there was one more gem, and do we have time to cover the other one real short?
Yeah, we can squeeze it in. And again, I'm just going to watch this again. I'm going to, usually I take notes, Tom, and I'll have, I'll have a page full. I could have a book full. And anytime you talk, that's just how it is. It's like drinking from a fire hose.
I appreciate that. Well, it's funny you mentioned the fire hose. I have the most amazing cartoon artist who does all my cartoon art for our websites and for our promotional stuff and for my videos and everything. His name is Ronnie, and he's in Indonesia. But anyway, and by the way, Ronnie needs more work. I'm being serious. If you at the Profitable Dentist or any of the dentists would like to hire an artist who works really inexpensively but does phenomenal work. I mean, anything you've seen of the Gems guy and all this stuff, it's all done by this guy, Ronnie. So he could use more work for his family.
Okay.
All right, that aside. And he would love the fact that you did some work, or maybe the dentist do some work with him. So I don't even know why did I mention Ronnie there?
About the graphics, that he does the graphics.
Yeah, I don't know why.
I just wrote down Ronnie's name.
All right, yeah. So email me. I'll hook you up with Ronnie. I don't know why.
Always come back.
Don't know why I brought him up, but the gem that I wanted to talk about, just to kind of squeeze in here. I just remembered why I mentioned Ronnie. This, by the way, is how my mind always works. It's not because of my age. I've been thinking this bizarre way since I was probably 12. Mm-hmm. You mentioned fire hose. Ronnie did a phenomenal graphic for me for one of my webinars. At the end of the webinar, I said, you probably feel like you've been fed out of a fire hose when you were just looking for a little sip out of my faucet. Mm-hmm. And so at the moment that I say that, I put up a full screen thing that Ronnie did for me, which is the Gems guy, which is a guy with this little thing, and it's an old miner kind of crunched over. So it's the Gems guy character, and he's got a fire hose and and it's hooked up to a fire hydrant. And there's a dentist whose mask is down here, and he's wearing his dental outfit. He's in scrubs, and he's being blown into the mouth by this fire hose. So the fact that you mentioned that, I've got that cartoon.
I've probably seen it. It's like a subliminal thing that because I love the artwork. I love your artwork, and if Ronnie's the guy who does it, it's all it's very approachable and very.
It's got to be fun. You know what?
I love the little guy.
You may think that we're different, meaning you the dentist and me the dentist, because now I'm doing this and I'm not doing that. But I used to do this same crap when I was in dental practice. Yeah. And dentists around me, I had one dentist come up to me in a restaurant, And I'd never met the guy. And he said to me something like, you know, I know the stuff that you do in your practice. Like, what are you talking about? I just had fun. I had fun. My patients had fun. We had a great time. We made good money and our patients got real healthy and my team loved what they were doing. So you can do that coming back. You can do it, but you got to be patient centric. So let's move on. I realize you've got a limited time.
Mm-hmm.
And I think my camera is actually almost out of film.
Oh, okay.
So that's for you younger people. Film was something we had used to put in the back of a camera and then drop off at CVS for a week.
You literally can't do it anymore. You to get film developed, you have to send it to, like, you have to send it away.
That's too funny.
Nobody does it. So
I remember going into the, I'll call it a drugstore with my film. Anyway, this really brings me back now. Before I touch on the target market, I got to tell you something funny. When I was going through the AACD accreditation, which was a gazillion years ago, I was actually the first dentist in Massachusetts accredited by the American Academy of Cosmetic Dentistry, if that tells you how far back it was. It was 1990. We had to take a gazillion slides and they were with film. And so you were like sending out film by the bushel full. And each patient you did had to be photo documented with all these different AACD views. The bottom line is we would have to send this stuff out and it wouldn't come back for a week or two. So we wouldn't even know if we had taken the photos right. It was terrible.
Right.
All right. So I love digital photography. It's so much better. I want to give you one more gem. I hope that what we've shared so far and gone back and forth with Steve so far has been helpful for you. But there's one more thing that's really, really critical, and this could be a game changer for you. So we'll talk to you next time. Thank you so much, Steve. No, I'm kidding. Here it is.
I always love time with you, Tom.
Your target market.
You can tell that I don't want to say that you don't take yourself too seriously. I think you take yourself appropriately seriously enough.
You know what? Again, I'm going to go back to you got to enjoy what you're doing.
You do.
I don't care if you're doing, you know, dentistry or you're doing what I do here or whatever it is you do. Life is too short, as has been proven by this crisis. Life is too short and too precious. And so I had a conversation with one of my, I hate to digress, but what you just said, I had a conversation with one of my members who's 70 years old. I was speaking with him this morning. And he said to me, he's in Connecticut and he's such a good guy. And he's quite successful. And he said to me, Tom, he says, we've always talked about the fact that I don't have an exit plan. And he doesn't really need the money. He's doing fine. And I've always said to dentists, and I'll tell you this, it doesn't matter if you are 36 years old or 63 or 27 or 72. I don't care how old you are. And I was saying this long before Corona. You have got to, and write this down, please. You have got to make a 5-year plan to be able to retire financially within the next 5 years. By 2025, you must be able to be out of dentistry. Now, that doesn't mean you need to leave dentistry. I hope that you love our profession. I do. I always did when I was in practice. I love what I'm doing today. But you must, within 5 years, be able to walk away if you had to. Now, pre-corona, why was I saying that? Right now, it's obvious why, because you would be in really good shape if you could walk away and didn't have to practice financially. That having been said, why was I saying it for the last 20 years? Real simple. Your hands, your eyes, or your back. Those are the three things that have crippled and taken out of practice more of my members, more of my colleagues, and more of my friends like that than you can imagine. And I've got one guy in New Hampshire, one of our members, who ended up with a degenerative eye disease where I don't think he's going to be able to practice any longer. I just don't. And he wasn't ready to retire. I had one of my members in Canada who had something happen to his hands, and it wasn't an accident. It was just something degenerative happened to his hands. Now, he was able to come back, but he was out for about 6 or 8 months. So again, you've got to make a plan financially so you could walk away if you needed to. The cool thing is something happens psychologically after you don't need the money. What will happen is your patients will accept your treatment plans, your bigger treatment plans, your most expensive, best, most comprehensive, life-changing for those patients. They will accept your recommendations far more readily when you don't need the money. Steve, why do you think that is?
I call that desperation selling. They sense it. They know it.
100%.
You need whatever it is that you need. They sense it and feel it. And I think your behavior is different. You don't know it.
It is. You're comfortable in your own skin.
Yeah.
When I was 46, I sold both practices and I could have retired at that point, but I didn't. I decided to do this. Why? I just love doing it. I love seeing other dentists coming back from a tough place, or those dentists who are doing really well, going from where you are right today. Maybe you're doing great, but you want to get to here, whatever it is you want to build. That's the kind of stuff that these little gems can help you with. And so if you do what I said a moment ago, which is you work out that 5-year plan so that in 5 years, you could walk away if you wanted to. Let's say you stayed in practice another 5 or 10 years. Well, your practicing will be very, very different for those 5 or 10 years. I will guarantee it. All right, I know you're out of time. Let me just run right quickly to the other gem I had talked about, which was target market.
Okay.
Our target market as dentists has always been, and Steve, I know you'll back me up on this, and even if you won't, you'll say yes. Our target market has always been women between the ages of 38 and 59 to 60, call it 60. So call it 40 to 60 or 38 to 60 really was what it was. Why was it women? Because usually they're more available. Usually they're the decision maker. There's a lot of reasons for the women. Why was it 38 to 60, 59 to 60? That was because that was the sweet spot for the people who would accept the care, the restorative dentistry, the people who were looking for makeovers and smile design and all that. So there's a lot of reasons, but that was our target market.
Okay.
I'm not saying that that shouldn't be your target market anymore, but it shouldn't be your primary target market. There's a new target market that isn't new. It's been around for a long time, but if you weren't already really heavily focused on it, now would be a really good time to do that. That target market is ambulatory seniors between the ages of 60 and 80. Now, I'm not talking about going in and doing nursing home dentistry, which is a different thing completely. I'm talking about ambulatory seniors who can come into your practice. They're fine. They're healthy. They're just older. I just got to tell you a funny story. I mentioned to you before we started the actual filming that one of my passions is volleyball. I've been playing volleyball for 40 years. I still play competitively at a national level. Unfortunately, USAB Nationals was just canceled, not canceled, but postponed. I was supposed to be playing with a Canadian team in Minneapolis at the end of May. But that team pulled out, and when enough teams pulled out, they canceled, and they said, hopefully we're going to redo it in the fall. I also play in the Huntsman Games, which is in St. George, Utah every fall, and then I play locally. Anyway, the reason I'm telling you this is that I'm still very active, still very athletic. And I mentioned to you earlier that I'm really proud that my daughter, who's 18, who'll be going to college in the fall, was just recruited by Cornell. She'll be playing D1 volleyball in the fall. So we're a volleyball family. So that's kind of the precursor to this funny story. I don't know if do most of the other states, I know Massachusetts are doing this, but it's a state mandate. Do the other states give an hour in the early morning to each of the grocery stores so you can go in if you're older or you're a senior citizen, so that you can go in a quiet time? Do they do that in the other states?
Indiana and Kentucky do. I know that.
Okay, so there are other places that are doing it. It makes sense because they're trying to give a break to the senior citizens who would have a tough time fighting the crowds and maybe getting their goods and things. So I decided, you know, I'm a senior citizen. I'm 62 years old, and the fact that I can almost touch a basketball rim and hit harder than most people have ever hit in volleyball, even at this age, doesn't make any difference. I'm going early. So I went to BJ's about a week ago to pick up some supplies, and I get there, the door's open, but there's a thing that says the line starts here, and there's people spaced out every 10 feet with their shopping carts as far back as I can see, and I'm, oh crap, I must be later than I thought. Look at the line here, this is terrible. So I went up to the front of the line, and I just asked the man at the front of the line, I said, what time do they open? Because it looked like they hadn't let anybody in yet, because there was nobody moving. He said, well, they're open for 60 and above right now. He said, but I'm not making any judgment. So I laughed. I said to the guy, I said, funny you should say that. I said, when I got an AARP card in the mail, I looked at the address. I said, maybe they sent it to the wrong address. Anyway, so target market, senior citizens. Why? Couple reasons. Number one, they don't mind coming in the middle of the day because they got nothing else to do. They're retired, most of them. So 60 to 65 and older, let's say 65 even, but retired ambulatory seniors. So number one is you can actually fill your schedule in the middle of the donut hole if you do it right,
Hmm.
because your other patients are going to want to come in those super early mornings,
Right.
those super late afternoon and early evening, and I'll guarantee you Saturday and Sunday will be amazing days for you if you're willing to do it. So how willing are you to change a few things that'll be a little bit uncomfortable for you, maybe even for your team, but to rebuild your practice to the point where you can thrive? What's another reason seniors are amazing? Number two reason is they like being in dental offices. They actually enjoy coming for the visits. Think about the seniors who you love to see. And sure, there's probably one or two who are a little craggedy like me, but there's a lot who are really just delightful people. They say yes to the treatment. They know how much they can spend, and a lot of them can afford to do the care, and so they make the decision to do it. So number two is because they're really great patients. Number three, and by the way, even though number one and number two are really good, number three is my favorite. The number three reason that seniors are my favorite is because they are full fee-for-service, because they don't have freaking dental insurance.
Right.
Dental insurance is the downfall of our profession. And you can see I get so mad at this discussion. I physically feel different right now just because I brought up the insurance question, but I want to tell you something. I had a conversation with Gordon Christensen about a week ago, and I said, Gordon, you and I did independent studies. We had talked about these studies only 2 months ago. So this is very recently, about 2 months ago. This is pre-COVID, maybe 2-3 months ago. He and I had compared notes. We had each surveyed our groups of dentists and asked them the question, what is your number one biggest concern, the issue that keeps you up at night? Now, he and I, we didn't even need to compare notes because the answer was insurance by a landslide. PPOs, not DSOs, PPOs, managed care, anything that requires you to be in network, sign a contract, and reduce your fees and basically give away dentistry. Right. And if you think about how much dentistry we're giving away today, it's sick. A dentist who's in PPOs and in managed care, which is most of us, a dentist who's in managed care, you're lucky if you're only right now 15 or 20%. If you're 15 to 18%, you've got some good contracts. I've got members who are 20, 25%, 28%. Right. I mean, how do you survive in a profession where the overhead is 60 to 65% and the required adjustment is 20 to 25% and 80 to 90% of your patients are in some network? If you think of the math on that, it's just terrible. Okay, so Gordon and I were talking about this just a week ago. And I said to him, Gordon, I said, it was only a couple months ago that you and I both agreed that the number one biggest issue for dentists right now is managed care insurance. It's terrible. It's breaking our profession apart. But by the way, in my Worcester practice, I took that over from my dad because he died of cancer. He had no money. He was in debt. He had no insurance. It was a mess. He had an 11-chair managed care clinic. It was a terrible mess. And when he was dying at the Mass General Hospital, he said to me, to Elizabeth and me, he said, please take the practice over and rebuild it like you did years ago. Because he knew I had gone through that, years ago and made mine successful. He said, my Framingham practice, he says, please take over the Worcester practice and do something so your mother has something to live on. Because he had nothing to leave her, zero, just debt. Within 3 years, we had eliminated, he had 15 managed care plans. Within 3 years, we eliminated 13 of the 15 plans. Now, we kept 2 of them because the fees were decent, but we were able to eliminate 13 of the 15 plans. So this is something that can be done. And then we totally sold a few years later. But before I sold, I turned them into almost fee-for-service practices, and my Framingham practice was totally fee-for-service. So back to the conversation with Gordon. Okay. So he says to me, yeah, he says it was managed care. He says, but it's not right now. And so we both agreed, the obvious is the 800-pound gorilla for every dentist right now is the COVID crisis, infection control, PPE, enough protective equipment, whether patients are going to come back, whether staff is going to come back. We had a call last night. This is the other reason my voice is as it is. It's not just the damage to my cords over the years of speaking. Last night I did a couple-hour webinar for my members, and several of my members said on that call last night that one of them's in New York City, and I won't mention the name obviously, but one of them in New York City, it's 2 doctors. 3 of their team said they're not coming back. They said they're too afraid to practice. and just there's a major shift happening in dentistry. So, by the way, Gordon did say something funny. At the end of the conversation, he said, yeah, Tom, he said, but you know what? He said, in a couple months, managed care will be their biggest issue again.
Yeah. Yeah.
And I think that's my story for the day, because I think we covered everything that I had promised that I was going to cover. Hopefully, maybe even a little bit more.
You did, as always, you know, drinking from the fire hose. No, and again, when you're, I get a lot of emails and people say, here, what can we cover? And I'll see all these different things. And I love the gems. The idea of thinking in terms of little gems that can just change your practice.
Simple stuff.
Yeah. And really, that's kind of what it is. Keep it simple. Maybe not.
Can I say one more thing?
Absolutely.
All right. If you are writing notes today, I want you to write one more thing. And this is kind of a much broader suggestion, which we work with our members. And in fact, we kind of drill this. This is on the very top of our dashboard. There's 4 letters. Write down TOBI. So if you were a member and you opened up your dashboard with all the, how's our ROI and how's our GEMS ratio and how's our hygiene doing, all this other stuff. At the very top of the dashboard, it says TOBI in capital letters. Write that down. It stands for the one big idea. The one big idea.
Okay.
Here's one of the worst things that we do as dentists when we go back to the team and we say, oh, I was at this lecture, I watched this webinar, or I watched this series that Steve did of 600 lectures in 5 days, and I got 6,000 ideas, and this is great. We're going to do all these things. Your team gets overwhelmed, and even doctor, if you don't, your team does get overwhelmed. So it's okay to have a list of 20, 30, 40, 50 things you want to do. And in fact, coming back from COVID, you should probably have a list of 20, 30, 40 things that you really need to do. Having said that, organize it. Don't show it to the team. Do not show it to the team. Organize it for yourself. Figure out, if you have an office manager, work with your office manager, figure out, okay, what are the top 5 things? So we've got these 27 or 92, whatever it is. We got this list that's this long. What are the top 5 things that are the most important that will give us the biggest impact when we go back for our patients' health, for our safety and health, for us rebuilding financially? What are the few not small things, but few most important things? Then pick 2. 1 clinical, 1 business. So you've got your clinical team working on just one thing. You've got your business team working on just one thing. So think about that from the team perspective. You go back in, you're having your team meeting, which you should be having every week. And if you're not, you need to start. In fact, in our top level coaching program, we won't accept them into the top level unless they agree that they'll do a 90-minute once a week team meeting. And we've had some refuse, including the one who's doing 5 million today. And she went up $1 million in the first year with us. Why? Because now they're doing team meetings. What she first said to me, she was very funny. She said, Tom, you don't know what kind of productivity we do. If we took 1 hour off each week, and she gave me some number, it was a crazy number, of how much they would lose. Well, they're taking off 90 minutes, not just an hour. They're taking off 90 minutes for a meeting and working on stuff together. So again, even if it's not 90 to 60, but meet once a week, work on Toby, focus on just that one thing. Think about the difference of how your team would feel emotionally if you said, here's the thing we're going to be working on, instead of here's the list of stuff we're going to be working on. Now, how long would I give them to nail Toby? In other words, how long do I allow my team, how long did I allow my 2 teams in the 2 offices to really work on one concept before I said, now we can move on to something else? A couple weeks, a month, even 2 months. Now, it shouldn't take 2 months. Most of the gems, most of the simple ideas might take a couple weeks, maybe a month. I'm going to give you a number. If one concept or idea or strategy, or in my case, gems, but one idea that you want to implement takes you a month. So you say, well, that shouldn't take the team a month to really get that working, but let's say it does. I'll give you a simple example. Our adult fluoride verbal skills. This is one of the ones that we start with because it's low-hanging fruit. It's so simple. It's 7 sentences. So if you can get, and you can, 80% of adults to accept fluoride at the end of the prophy visit by using 7 sentences that the hygienist can learn in about 20 minutes, that's about a $40,000 to $50,000 bump per hygienist per year. Now, I just said you could learn that in 20 minutes. Why would I give them a month? Here's why. And by the way, It's not going to take them a month. Whatever the gem is that you're going to do, whatever it is, it's not going to take them a month. But the reason I'm okay with a month is this. It takes all the pressure off of your team. Your team in normal good days, in normal circumstances, has all sorts of pressure, not just from you and from the practice and from the patients, but from home as well. So give the team a little bit of distance, a little bit of slack, a little bit of wiggle room, and realize that they need your emotional support now more than ever. So take the pressure off, work on just one thing at a time. I said I'd give you the math. Here's the math. Let's say you did fluoride verbal skills for 50,000. This sounds like Jeopardy. Fluoride, what's the guy's name who did Jeopardy?
Alex Trebek.
Yeah, Alex, I'll take fluoride for 50,000. So yeah, that's what it sounded like. So fluoride for 50,000. All right, and let's say that's your clinical gem. Let's say your business gem is the other one I already mentioned today, which was long-term internal advanced financing. So you got a patient who couldn't go to Care Credit, or they did and they got turned down, tried Capital One, they're turned down. They're walking out if you don't do something. So as long as you're following all the steps of risk mitigation, which would take us another hour if we had another hour, which I don't think we do. Anyway.
We'll come back and do another one.
I'll do another one. I'll totally do another one. I'm actually doing an all morning interview tomorrow, not me, but me interviewing somebody who does, I can't think of how they describe it, but basically it's eliminating the risk of aerosolization actually hitting the team.
Yes. Yes.
And it's a fairly new company. And I said to the guy, I said, we got to do a video. So we're doing probably about a half a day filming tomorrow. Anyway, watch for that on YouTube. I might mention that my YouTube channel is the same name as my website. It's Dental Goldmine. So that's the YouTube channel, and that's free. Okay. So looking at the math. So let's say you did internal long-term financing. I told you that we did about $400,000 a year between the two practices, so maybe $200,000 per practice. Let's say you don't do $200,000. Let's say you do $100,000. So what would it take to do $100,000 in internal long-term financing? The math on this is sick. It's so easy. Your practice in good days has at least two patients who left the hygiene room. You had recommended some care, not a big implant case, not a big cosmetic case, but a little bit of care. Maybe one crown, a buildup, a filling, some scaling. So call it $1,500. So again, this is not a big case. You've got at least two patients a week who are walking out not doing it. They wanted to. They went to the desk and they talked to the team and they said, I totally got to get that done. I really understand the need immediately, and then you talk through the financing and they just couldn't do it. So there's at least two people walking out with a little tiny case of $1,500 twice a week. Well, how much is that? That's 3,000 times 50 weeks is $150,000. It's $150,000 walking out your door. If you ever ask yourself, how do those doctors do $2, $3, $4, $5 million in one location? The answer is because they're doing a whole lot of stuff that you and I never thought of years ago, that finally I caught on to after a while, was able to rebuild my practice from death's door. See, I didn't tell you this one, but when I said I was in that terrible, terrible situation where I'd created my own recession, I call it my perfect storm year. I was told on a Friday afternoon in October by a Boston bankruptcy attorney, I will see you at 9 o'clock in court on Monday. And had I gone to court, I didn't, I avoided it. But had I followed his instructions and gone to court on Monday morning, I would have lost my house and my dental practice, and I wouldn't be standing here talking to you guys today, because I don't know what I would have done, because I had $1 million in debt and I wouldn't have had a house or a practice.
Right.
So I've been there. Then my dad's practice was in that kind of shape, and we fulfilled the promise that he asked me to promise, which we did promise him right before he died, which was to turn that one around. And that's what I've been doing now for the last 20 years. So the math, here's the math. 150,000, even if you only had one patient for, let's say 1,250. So 1,200, one crown, a buildup, and a filling, it's tiny stuff. If you're doing internal long-term financing for patients who are going to walk out because you've tried everything else, you will add at least 100, if not more. You'll add 50,000 in fluoride. So if you ask yourself, why am I saying it's okay even if it's a month? By the way, I tell my members it's okay even if it's 2 months. Do not pressure your team to do too much at once, because they will They will work for you harder than you're asking them to if you don't work harder, if you don't ask them to work harder than they really can.
Mm-hmm.
They're going to be going back and doing so many more things just because of the infection control and talking to patients about all this. So let's say they only did one a month. And let's say it wasn't a $100,000 increase. Let's say it was a $50,000 thing. So really like the easier stuff. 50,000 times 12 months in my math without a calculator is still 600,000. Is that right?
Mm-hmm. It sounds right.
So 600,000.
Mm-hmm.
Would you accept a $600,000 increase? Oh, I have one more comment, if I may.
Mm-hmm.
One of the questions that's been coming up a lot from dentists, and I get it from my YouTube followers. I get it on my Facebook group. Did I mention I have a free Facebook group and it's called Dental Goldmine?
No, but I wanted to make sure you did.
Yeah, come to my Facebook group. It's called Dental Goldmine. I will tell you that there are requirements. Seriously, you must be a general dentist in private practice, small group, or private solo practice. So if you're in a 5 or 10, 10 or 15 group, I appreciate that. It's probably an awesome group, but that's not for you guys. If you're in a DSO, it's not. If you're an orthodontist or periodontist, it's not. But if you're a general dentist and you're trying to slug it out in the trenches like the rest of us, and like I did, and like you are today, then we'd be happy to have you there. We just started it, 8 days ago or something. It's brand new.
Okay.
We've got close to 300 members in 8 days or something like that. So we would be happy to have you. So it's Dental Goldmine. It's also dentalgoldmine.com. But I did have one more comment. I just don't know what it was going to be. So let me see if I can dredge it back from the trenches here. Oh, I'm glad I remembered it because it was something that I heard on my call last night with my members. And this is really important because it is on your mind, I will guarantee you. I had several of my members, sorry, I had several of my members asking me last night, okay, so you've got gowns, you've got N95 masks. A lot of doctors are double masking, so you got double mask. You've got gloves. You've got new aerosol mitigation systems. You now have face shields all the time. I mean, you've got, I don't even know what it's going to cost. I was thinking about this morning, trying to figure out what's an estimate on what that is per patient. Infection control used to be a couple bucks a patient. You turn over the room, spray this, spray that, throw these things out, dispose of those, sterilize these, and it was a few dollars, $2, $3, $4, $5. And even when we started doing all that, we got the same question, which is, can we charge that to the patient?
Right.
There were some who did. There were some who tried to charge their patient an infection control fee. You guys are aware of that. Some did it. Some probably still do it. I will tell you, it's the worst thing you can do with your patients. What were the two words I started with today? Patient-centric. Patient centricity. This is all about patient centricity. So the worst thing you can do is go back into your practice and let them know that it's costing you a lot of money that you can't afford and you're going to charge them for it.
Right.
So I get that question a lot, not just about just infection control, but I get the question about overhead in general. What's a really good way to reduce our overhead? Well, that would be a subject for another day. But I will tell you the easiest way to reduce your overhead percentage. So let's say your overhead percentage is 70%.
Okay.
So for every dollar that you collect, not produce, because a lot of you guys are writing off a lot of money, but for every dollar that you collect, you have to spend 70 cents of it on team and insurance and whatever, your rent and supplies and lab and all that. So you're left with 30 cents on the dollar. What's the easiest way to change that percentage? It is not by penny pinching your overhead. Now, I'm not saying you shouldn't be looking for the best supply costs and totally do all those things. You got to do all those things to survive and to thrive. But if you spend too much of your time, effort, or energy, and if your team is asked to spend too much of their time or effort or energy on trying to get supplies down from, if you look at, going into another subject here, but if you look at overhead, what's your biggest cost? Team. Where should that be? 20 to 22%. If you're at 25%, you're maxed. If you're over 25%, you got a problem. So I'd like to be at 20%. 22%, still fine. Includes hygienists, excludes doctors. Okay. So what's your next biggest expense? Lab. How much is lab supposed to be? You should be for lab somewhere between 7 and 12%. Why such a big swing, Tom? That doesn't sound right. It does sound right. Here's why. If you're a prosthodontist or if you're a GP doing a lot of implant work and you're looking at a lot of lab work and you're using higher end labs, you're going to be in the 10, 11, 12% range. And that may be okay because you're probably cranking out some big dollars. But if you're a Crown and Bridge, if you're a bread and butter general dentist, just doing regular general dentistry every day, then your lab is probably in the 6, 7, 8%. So there is a swing there. Now, there is a caveat. If you've got CEREC or any of the other imaging systems where you can do CAD/CAM, your lab fee is going to be a lot less, but now you're paying both for that system, which was anywhere from, in the old days, 60 or 70,000 to today, 150 and up, depending on your system. But you also have to be paying for the blocks. And so you're basically trading one for the other. So where do your supply fees, excluding CAD/CAM, where do your supplies fees fit in? They're only about 5%. Okay, so if supplies down at 5%, what do you think it would take for your assistant to shave 15% off of, not the 5%, but 15% off of the total dollar value that you pay on supplies every year? It's not going to be easy, but she could probably do it. I say she, it could be he, but whatever. What would it take for you to drop, again, so follow me here. I'm not talking percentages. I'm talking about real dollars. So let's say you're spending in real dollars. Now I got to do some math without a calculator. Let's say you're $1 million practice and you've got $50,000 in supply fee. Is that 5%, I think?
Yep.
Okay, so 50, again, I use calculators all the time. So $50,000 in lab fee. I'm sorry, $50,000 in supplies. What would it take to save 15%, to shave 15% off that? Well, it's going to take her a lot of work, a lot of time, comparing this, comparing that, looking at all the new specials, looking at the risk versus reward of buying a lot of stuff at once because there are quantity specials. You're gonna be paying a team member to do a lot of stuff and a lot of time, and it can be done. So you could save 15% off of whatever unless you've already been really, really, really good at it and you've already got it to the bone, in which case you can't. But let's say you can. That 15% isn't saving you 15% off that $1 million. That 15% is saving you 15% off of 5%.
Right.
Well, 10% off of 5% is a 0.5%, which means we're talking about 0.75%. Now, devil's advocate, am I concerned with the amount of time because I'm going to be paying her for that time? Not so much, because let's say it takes her 5 hours a week or whatever it's going to take her to do that really good job of that. That's not so much money. I have no issue with that. Where could she be better spending that 5 or 6 or 10 hours a week instead of trying to nickel and dime those supplies down a little bit? She could be selling dentistry to patients. She could be building relationships with patients. She could be bringing in referrals. She could be doing so many other things that will be better than. So again, I get kind of upset about this because we as a profession have been too focused on reducing overhead, and you've got to. Please don't. If you take this out of context, it's going to sound like the GEMS guy says you don't need to be looking at your overhead. You do. I am all about the analytics and the numbers, and my wife, Elizabeth, who we call the engineer because she is an engineer, she does the analytics side of GEMS, and so she is all about spreadsheets and analytics. So she would agree you need to be careful with your overhead. But the easiest way, this is going to circle back, and then I think we're done. At least I'm done. And I apologize for that.
You're good.
This is through the magic of Go technology, by the way.
Right.
So if instead of nickeling and diming the overhead down, if you just put, let's say you called Shine or Benko or whoever you're getting your supplies from, and you said, you know what, we've been buying a lot from you, but we've also been buying a lot from 2 or 3 other suppliers. Plus, we've been looking at specials online, and post-COVID, here's what I want to do. And by the way, we've had members do this, and it works. Post-COVID, here's what I want to do. I want to focus on my patients more. I don't want to be sitting there going online, looking at all these specials, calling 3 other reps from 2 other companies and you. I want you to do all our supplies. If you are willing to give me and whatever the number is, it might be 20% across the board reduction in your online lowest fees, whatever you got. I don't know what will be reasonable for each company. So you got to come up with something that you think is reasonable for each company. Whatever it is, it's going to be a big savings for you.
Mm-hmm.
And I will tell you something. If they don't, the next company will. I know this for a fact. It's being done by my members. We got this idea from one of our coaches from our program. She's a hygienist, and she does this for her office. And once our members started hearing this during the coaching, they said, it actually works. We called and we said, okay, well, if you'll just give us this, we'll give you all our supply orders. Now you're only dealing with one rep, one inventory system, and you're already getting their best pricing because you're being guaranteed whatever that percentage is off of their lowest online. Okay. So what's the easiest way to decrease this? This circles back to the end of that whole conversation, which gets me really kind of riled, because there's a better way. The easiest way for you guys to reduce from, let's say it's 30% net, 70% overhead.
Mm-hmm.
If you want to go from, 30% net up to 40% net,
okay,
the easiest way to do that is to increase your productivity without major increases in your overhead. So how do you increase productivity without increasing overhead? Okay. If you were to increase $200,000, $300,000, $400,000, $500,000 in the next 12 months, above where you were, not where you're going to be when you come back, but above even where you were pre-COVID. If you went up $200,000, $300,000, $400,000, $500,000, would you have to add another full-time staff member to do a few $100,000 more? Probably not. Now, I don't know the size of your staff. If you only had one staff member, you might. But if you had 3 or 4 or 5 staff, or 2 assistants, or 3 people in there and a hygienist, whatever, if you have a typical small, average-sized dental practice, you do not need to change staff or increase staff to increase $200,000, $300,000, $400,000. You just don't. Okay. So staff, that's out. Would you have to change your facility? Of course not. Would you have to add more equipment? No. Would you need any new toys? No. You just need to implement the ideas you've been learning from Steve in the group over the last week. So if you take all of those ideas and you rule out, for the time being, any of them where money was suggested, like if somebody said, get this laser or get this CAD cam, those are good things. But for now, stay really, really, really tight. The dentists who are going to do the best are the ones who are going to invest in their team, in continuing education. I know a lot of you guys have been taking a ton of really good continuing education, so keep doing that. So let's look at the numbers. What is the actual cost? And this is real numbers. What is the actual cost of let's say it's a $200,000 increase? What's the cost of a $200,000 increase for $1 million practice? If you didn't have to add any team, you really didn't buy any equipment, you didn't change your insurance, nothing. It was really just seeing the patients and doing some things that would help patients perceive the need for care, accept better care, finance them a little bit better, and so forth. So what was the cost? Well, there's only 2 costs in there. I'm sorry, there's 3 costs in there. There's office supply, dental supply, and lab. So in that next $200,000, if you don't add any team, don't change your facility, don't add any new equipment, don't change anything, don't spend any more money. But the only thing that you invest in is office supply, lab, and dental supply. You're looking at 5 combined. Your dental supply and office supply should be less than 5%.
Right.
And then if you take your lab, let's say you're in the mid-range, even if you're in the high range, if you're at 10%, you won't be at 10%. Let's say the whole thing is 10%. So you might spend, of your next 200,000, it's going to cost you about 20,000. It could actually be 25,000, but for easy numbers, let's say 20,000. So your next, I'm going to play devil's advocate. Let's say you're sitting at home saying to yourself, that's crazy. It would cost me way more than that. All right, fine. I'll give it to you. $50,000 in costs. It won't, by the way. But let's say it was $50,000 in costs. So now, out of the 200,000, you're only netting an extra 150,000.
Right.
Okay. You used to be $1 million practice, netting 30%, spending 70% on overhead. You're doing $200,000 a year more. You're spending an extra $50,000 in overhead, which you won't. But let's say you did. So 50,000. So you got 150 net. You were taking home. This is crazy math. You were, but very accurate. You were taking home 300,000. You just added 150,000 net. Your net income just went up. Your take-home pre-tax, your net income pre-tax just went up 50%. Can you see why you shouldn't have your team nickel and diming overhead, and why you got to be careful with overhead? But that having been said, Your focus should be on increasing, not production, but collection. You have to increase your production, but do it wisely in ways that you reduce your write-offs to PPOs and all that as well. I think that's probably it for me. I appreciate the opportunity. That was an amazing 20 minutes.
Yeah, it was. You know, you crammed a lot in there. It's like condensed.
Was it 20 minutes?
Ballpark. But yeah, and as a business guy, Tom, I'm always a believer in you know, you can't cost cut your way into business growth.
100%.
You know, it always comes from the top line. And you know, it's funny, I've said that before, and I'll have a room full of dentists. They'll do, I wrote down your little, the bobbleheaded dog. They'll shake their heads and I'll say, you know, you've got to focus on your top line growth, as well as your bottom line growth. But if you focus on it up here, don't add any new costs, any new overhead, you know, you're taking home, as you said, you're taking home 40 cents or 50 cents of every dollar.
It's crazy.
Instead of 20 cents.
I got to show you something.
Yeah.
All right. So I mentioned that one of my mentors, nobody has ever seen this before, by the way.
Oh,
I've never shown this.
So this is a Profitable Dentist exclusive right here.
It is. I've never shown this on a video. The only dentists who in the world have ever seen this are dentists who've come to my retreats, because we start our fall retreat with a huge dinner in my backyard and in my house, and then we go to the hotel for the rest of it. But so they've seen it in my office. But check this out.
Oh my gosh.
You know who this is?
How do you get that made?
Do you know who this is?
It looks like you.
Nope. This is Dan Kennedy. No BS marketing.
No, Dan Kennedy has his own bobblehead?
Yeah.
On a cow?
This is the Dan Kennedy.
Now the cow. I get it.
Yeah, it's no BS marketing.
It's the mustache. That's awesome.
Yeah, well, Dan gave that to me, but anyway, yeah, you can't cost cut your way. I wanted to take just my final couple words just to thank you, not just for this opportunity. I always appreciate the chance to talk. I do. I love doing this. So I appreciate the opportunity to share the gems, but more so, I just wanted to say, I am so happy that you have done what you have done with the Profitable Dentist. Because as I said, they gave me really my start. I had done small audiences, you know, 200-300 people in a local dental society. I had done probably 300 was the biggest thing I'd ever done back in the 80s and early 90s. And back in the day with Woody and Travis, on the top of that mountain, that was the biggest break I had gotten, because, you know, they believed in me back then, which was really nice. And the fact that you have now carried forward the mission that really it was Woody, because Travis was out a while back, but really that Woody set forward, and a lot of us followed Woody for, you know, for the ages, for the decades. So thank you for doing what you've done with Profitable Dentist.
Well, I appreciate that. And that really is, I always say it's, you know, what Woody started, or the idea is baked into the DNA of what we do.
Yeah.
You could get lost in a lot of things. I always also feel like the, you know, dentistry is a little as a cottage industry. It's a mom and pop industry.
That's what my father used to say.
Yeah, it's sole practitioners. It's, you know, we have some giant corporations, but they're still in single digits in the percentage of dentistry that's done. It's, for the most part, it's, you know, it's guys like you.
My dad used to say exactly that.
Yeah. So that's what I try to focus on. And, you know, that's hard to do sometimes. You know, I went to Indiana University School of Business. I'll rattle off things like top line and bottom line and margins and all this. And you know, you can get into a trap where you assume that the audience knows. Well, you went to dental school. Margin's a whole different thing to you. And so it took me a little while to back up and realize that what I have to bring is just that focus. Woody did a great job of understanding that you're sort of all in it together. You have the same struggles, the same challenges, the same fears, but you also have the same tools and opportunities if you use them right. And I appreciate everything that he's done. And we actually created a room that maybe I'll turn it into the Profitable Dentist Museum. There's a lot of you in there too, Tom. So I'll share some things with you. But it's
Please do.
know, his message is still just as valid today as it ever was.
100%.
We can be afraid of DSOs, but you know, I won't be around when that changes, when that flips. The industry is still dominated by sole practitioners who went to dental school and really want to see patients and take care of them. you know, they just happen to be the owner of the business too. So
Mhm.
they have to tend to that and nurture that. So, but thank you for that. So here's a question. If somebody wanted to get a hold of you, how would they do that?
Oh, that's a good question. I hadn't thought of that.
Right in front of my eyes.
No, I hadn't thought of that. But they could go to dentalgoldmine.com.
Okay.
And that would probably be the best way is dentalgoldmine.com, because we make it kind of easy on that to get some gems for free. So if you go to dentalgoldmine.com, you can get some gems for free.
I think anybody listening, I would strongly encourage that. You know, Dr. Orent is very humble in what he shares, but he shares a lot. And one of the things I appreciate is how I think gems is just spot on. You sort of package little nuggets. You know, you were talking a while ago about your long list, your Toby. And I was thinking, you know, that list of two are your first 2 bites of the elephant. You know, they say, how do you eat an elephant?
Yeah.
And you've got a list of 92. Those are your first 2 bites.
And it's true. Just take a couple bites and you'll get there. And focus. Just write down, just to wrap it up, just write down, focus on Toby. T-O-B-I, the one big idea.
Awesome. So I think with that, yeah, we're right at 20 minutes. Seriously, you are a wealth of information, always have been. I think a lot of practice owners owe the success of their practice today, or maybe even the existence of it, to what you've been able to do.
You're very kind. I appreciate that.
Yeah. So with that, practice owners, Dr. Tom Orent, the Gems guy, dentalgoldmine.com. I would highly suggest you at least go poke around, take a few gems. You know, I think when you decide how you're going to come back, you're going to find a lot of those really make your comeback smoother and easy, and certainly more profitable. So with that, we're going to wrap up another edition of Coming Back Stronger. Dr. Orent, until next time.
Steve, thank you so much. Be healthy, be safe, take care.
Thank you. All right. Bye, practice owners.